everyone, we're going to get going. Okay, right. So welcome to Suitcase Club. Today, we are doing the STIs for the converted. This was Alvi's. So STIs being schistosomiasis testing instructions. So the reason being, we've just had a recent sort of what we've noticed, I guess, a spike in people getting diagnosed with Bilharzia, sort of whether they've had an exposure or not had an exposure, and based what we believe on incorrect interpretation of the laboratory tests. So yeah, Praziquantel being out of stock, which we hear now some select places may or may not have. We haven't, I mean, it's not mainstream yet that we can send a patient to a pharmacy and go get it, but that being another complication to add to this, yeah, this sort of dilemma that we had. So we have asked Dr. Pieter Ekermans to come and chat to us about basically a little bit about the disease and how to diagnose it correctly. There's a little bit of a summary there on the screen, but I just wanted to read a little bit. So Dr. Ekermans was graduated from the University of Stellenbosch in 2003. He then did his DTMH at Wits and then continued on to do his clinical pathology M.Med also at Wits. Currently is working at the National Reference Laboratory in Centurion, and he is a clinical pathologist. And I did see here we've got all kinds of things. So microbacteriology, TB laboratory, molecular biology, and medical microbiology. So there's lots of things, and I've had a look at these slides and we are in for a treat because we have a lot to unpack here. It's not as easy as all that. So we're going to hear a little bit more now. Just a little bit on, I'm just going to go, you guys have all seen these if you've joined us before. We are coming to you live from Fire Station Rosebank. When it's not so cold and dark, you must come join us. We do have a beautiful sunset at the moment, but if you are able to come through to the clinic for a meeting, please come and join us here. We have the meeting here in the boardroom first Thursdays of every month. Suitcase Club is just a little bit of a way for us to sort of get what's going on in the world up to date. Being Joburg being sort of our center for travel, I guess, around South Africa. And we're also doing it just in hopes that we can get a little bit of information for GeoSentinel, which is actually it's a joint venture between ISTM and CDC. And it's a way for us to, if we get a travel-related illness, we notify via GeoSentinel, and it's a way for them to pick up early outbreaks of diseases that are travel-related. So it's always nice for us to contribute to that initiative. This is how you would go about informing us. There's an email address. You can chat to anyone, Albie, me, whoever is available. And if you have any travel-related illnesses or if you have any questions, to reach out to us as well. I'm going to skip over these for now. Not the other big thing is that we are recording our lectures and we are uploading them onto our YouTube channel. So everything that we do, if you haven't caught the meeting in real time, you can see it later on our YouTube channel, which is nice. And it's just a quick thank you to MSD because they always, well, not always, but today we have MSD providing us with snacks. So we have some yummy snacks here, and then if you join, then you get to partake in those in person. So I'm going to stop sharing my screen and we're going to hand over to Dr. Ekermans now.
All right. Good evening, everybody. Thank you. This is going to be a whirlwind tour in this very interesting world of schistosomiasis or Bilharzia. On the screen, we're seeing this interesting interaction between male and female worms. And in the top 4 pictures and on the side, a female worm is inside the gynecoporal canal of a male. And they have that prominent ventral sucker, and right at the top, a sucker part around the mouth as well. And it uses that sucker to move through the body against the direction of the blood flow. So we are going to delve in deeper here. So that's an interesting member of the trematodes because it has 2 sexes, where the others are hermaphroditic. And they remain pretty much for much of their life in copulo and they can live for beyond 3 decades, which is quite interesting. Some articles say these pairings are not permanent and there's some competition between the males. And then interestingly, one wonders how this thing lives. There are transport mechanisms in the tegument of the worm. It has a hemoglobinase to digest hemoglobin, to get amino acids. It uses facultative kind of mechanisms to degrade glucose and glycogen. And interestingly, the different worms, the top 3, Mansoni, Japonicum, and Hematobium, they differ in the number of eggs that they shed. Japonicum and Makongai and other species, up to 3,000 in some texts. And so interestingly, the history is just fascinating. This goes right back to the world of mummies. Napoleon had some drama in Egypt at the end of the 1700s in the Anglo-Boer War, 1899 to 1902. There was some suffering in troops. Bilharzia comes from Theodore Bilharz, and their work comes from 1851. And then obviously Mansoni did some work in the Caribbean. And then fascinatingly, in China, Mao did this amphibious assault on Taiwan in the late 1940s. And many of the troops got Katayama fever. And so later, in the so-called Great Leap Forward, he mobilized thousands of workers to bury the intermediate host, the Onchomelania snails, along the clay banks or remove them by hand in order to deal with this onslaught on the troops. And that proved to be an effective control measure. And then in our own country, if you look at all the articles, a lot comes from Natal, and this British physician and zoologist, Dr. Corsten, in 1918, started speculating on the modes of transmission. And in those early works, not yet mention of the snails, but they knew there was a link to freshwater exposure, more common in boys and girls, and some texts tracing it back in South Africa to as far back as 1864. The highest prevalence is on our continent. 1 in 40 of all humans are estimated to be infected. It is linked to morbidity and mortality. Most individuals, interestingly, have mild to moderate parasitic load, and then only a few end up having heavy infection. And obviously, a lot is to do with the exposure patterns and the distribution of the intermediate snail hosts. So this is an initial version of the WHO map of the globe indicating the situation. The bulk of the color comes from the African continent. And just today, this is from the WHO dashboard. And you can pull this data and you can see currently figures in Africa at 231 million plus, and globally 253 million plus. Slightly worse off with those green areas coming into play, China, Saudi Arabia, etc. And so Mansoni, Hematobium, and Japonicum are the top 3 species to think about. Their intermediate hosts are different, and their spread is also slightly different. Mansoni, a little bit broader, including parts of South America, often Brazil, the Caribbean, and the Middle East, in addition to Africa. Whereas at the bottom, Japonicum is in parts of China, the Philippines, and Indonesia, the island of Sulawesi. And their clinical manifestations are slightly different, and we will delve into them more. and their primary hosts is, as you can see here, can be just humans and primates, as in Hematobium, and quite a vast array of mammalian hosts. So Japonicum is a primary zoonotic species, anything from dogs, cats, right up to water buffalo. Lesser species or minor species also have a place on the map. Makongi from the Mekong River Basin in Laos and Cambodia. Schistosoma malayensis endemic to Malaysia. There's also a different species for the top two on this table. Intercalatum, which is closely related to Hematobium, from what I've read, can also be transmitted through the Bullinus species. And here, these four pretty much are tropic for intestines and liver, and not as extensive in their definitive host or zoonotic reservoir. Then there's a lot about hybridization and what they call I hope I've got this correct, introgressive gene transfer, where there's this transfer of genetic material from one species into the gene pool of another through hybridization and repeated backcrossing, involving movement of genes from hybrid offspring back into the parents. Professor Queen, is that correct? Yes, yeah. And obviously, this probably is going to get worse with global warming and changes in environmental conditions. And so in South Africa, it has been documented hybrids of Hematobium and Mathii from cattle in endemic populations and in travelers. And then in northern Senegal and Mali, there was a hybrid that came from Senegal it sort of got introduced into Corsica and France. So this is an evolving sort of field. So you need exposure. And you need to decide when you look at the case are we dealing with exposure in an endemic area, or are we dealing with exposure in travelers? And in this freshwater environment, it needs to be where the snails can live. And obviously in that water is the infective larvae, the Cercariae. There's also in some texts some information about a minimum water temperature, although one outbreak seems to have been documented in Uganda in a crater lake where temperature changes occurred. Worm burden is often among children in endemic areas. It increases gradually and culminates in adolescence. And on the adult side, it's linked to occupation as well as recreation in those endemic areas. So this was an interesting outbreak in Brazil, and it documented men who came from an endemic area in northeast of the state, Minas Gerais, and they were employed to build houses and restaurants, but they stayed in impoverished shelters without sanitary facilities, and they used the local waters to bathe and to dispose of their feces. And unexpectedly, those waters supplied a swimming pool that was used by the local population. And this area where this occurred was considered non-endemic. So I thought that was quite interesting. Travel infection can be acquired following a single exposure, and we'll delve into that going forward. So here, these were visitors that went to the Dogon area in Mali. There were 29 patients from the Netherlands who had swum in freshwater pools. and 97% became infected, 36 had dermatitis, and 54% Katayama fever. So this was, I think, at the late 1990s, this publication. Then this was an interesting case of 34 Israeli travelers that visited a lake in Tanzania, and they had a short exposure of 40 minutes once off, and 27 had a single exposure of freshwater pond, and 81% were infected. And serology was used, positive in 15 of 22 persons. So in South Africa, Limpopo, Mpumalanga, KwaZulu-Natal, and the top parts of the Eastern Cape are the hotspots in our country. And this is from Prof. Vrien's work, where they did a descriptive analysis on secondary data from the NHLS, capturing over 100,000 cases. And it was highest amongst patients between 15 and 19 years. There was ongoing endemicity in the Eastern Cape. And I must say, studying at WITS and doing my 2 years at PE and the NHLS, I hadn't realized at that point to what extent what was going on in the Eastern Cape. And Vanessa, the lab manager from PE, told me that no, there are hotspots, and this is not unusual for Port Elizabeth. And Port Elizabeth was sort of the big hub, in addition to East London, for work to be done in that province. And interestingly enough, from the map you'll see shortly, the Western Cape and Gauteng flared up. But the authors ascribed this to imported cases, obviously due to migration. And from this work, an average of 36 people per 100,000 were infected annually. And in the map, you can see Gauteng and the Western Cape on the light side, and the bulk from Limpopo and Mpumalanga, KwaZulu-Natal, and then the Eastern Cape. I don't know, Professor Vrien, do you have any comments? Does that capture?
Yeah, so the it's laboratory data.
Yes.
So the map reflects where the cases were died.
Yes.
Not necessarily where they originated.
Yes. And it was interesting. I found a map, and this now looked at the vectors, and these plot Bulinus africanus, globosus, and Pfeifferii, and you can see it sort of matches what this map looks like. To realize it's a category 2 notifiable condition, so written electronic notification within 7 days by healthcare workers, private health laboratories, or public health laboratories. This was 34 travelers, and it was cases that presented to Belgium, to the Tropical Medicine Institute in Antwerp. And it was a woman and 2 kids referred by their family doctor 3 weeks after a stay in Witrifuur. Both children presented with headache, cough, eosinophil count that was elevated, mom was feverish, and it turned out that there were 34 adults belonging to 8 Belgian families traveling in 2 groups. Can you imagine what happened in Belgium when they got this? All had swum and rafted up to several hours to sections of the river with reduced water flow downstream from a cattle crossing. Absolutely fascinating. So the life cycle begins with seeding of eggs in the fresh water through urine and feces from infected humans or animal reservoirs. Just to put them side by side, the life cycles are similar, and interestingly, Japonicum, this comes from Despomier's book, Tina, that I sent you guys, the latest version 8, corpulmonale CNS damage and hepatosplenomegaly in Japonicum. And linking the humans and the snails are the Myricidia in the middle, and you can see on figure 33.9 how it leaves the egg, and then the Cercariae from Schistosoma mansoni. So this is the life cycle. So those Myricidia, when they hatch, are viable for a couple of days. And interestingly, there's a pheromone chemoattractant system that it uses to latch on to the appropriate molluscan. In the snail, there are 2 generations of sporocysts, and they are released 4 to 6 weeks in Cercaria form. And these Cercariae just up to 2 days are infectious, generally for the first few hours, in fact, but not beyond, it seems. Upon release from the snail, they penetrate the human skin, they lose their tail, and they become what is called a schistosomula, and then they migrate, and over 2 to 4 weeks, they mature into adults. And so then there's this propensity for different locations, the mesenteric veins or the venous plexus. So they use that sucker to migrate against the portal flow, if I understand it correctly. And Japonicum and Macongai tends to favor superior mesenteric veins, mansoni inferior, and sometimes the Japonicum escapes for the choroid plexus around the spinal column as broad strokes, but obviously this can always catch you out because things wander. Deposit eggs in small venules of the portal and perivesical systems after 1 to 3 months, and then they describe this movement of the egg through the tissue using proteases and things to then reach the lumen of the appropriate organ. And so much of the clinical disease is linked to the host's response to these eggs. And the adult worms are quite nifty because they hide from immune attack. And it seems like, if I understand it correctly, they have an ability to produce blocking antibodies, or at least it's proposed as a mechanism to survive. And entrapment, inflammation, and fibrosis then lead to what we see in the chronic phase. There's a T helper 2 immune response often, and this eosinophilic granulomatous reaction, or the histologists love talking about the Splendori-Hoopley reaction. Katayama fever is described as resembling a serum sickness type picture. In the liver, we will see fibrosis phenomena. In the bowel, ulceration, blood loss, and scarring. Granulomas, ulcerations, and pseudopolyps can be seen on the bladder sign. And this can lead to hematuria, scarring, and calcification. And then interestingly, the link between chronic inflammation, schistosomiasis, and bladder cancer, which is squamous cell cancer rather than transitional cell cancer, which is also quite interesting. What in this inflammatory repair and scarring dysplasia sequence of events makes that more prominent. And so this is sort of a summary slide, which a few years ago, Prof. Freen shared his DTMH slides with me, and I tried to squash it all into one pager to focus on the principle. So acute, we're talking about days to weeks. Chronic, we're talking about months to years. In the acute side, it's linked to invasion and maturation with early laying of eggs, whereas chronic, it's more established egg laying, and then phenomena linked to fibrosis and ectopic sites outside those initial places where the adult worms go and reside. And so another way to think is that often the acute infection tends to favor travelers in broad strokes, whereas chronic tends to favor your endemic migrant kind of populations. Somersets obviously can also be in endemic areas. And so quickly to go through, they call Somersets also clam diggers, which I thought it was interesting. And it's a localized dermatitis that causes a pruritic papular or urticarial rash. And there's also a link to avian schistosomes. But these schistosomes don't go beyond the skin, they die. And so there's different genera, Austro, Tricho, and Ornithino Bilharzia, that are linked to exposure with avian schistosomes in the environment. And this is the best picture I could find about Summers itch, child suffering with a maculopapular rash. And on the Katayama syndrome, it seems like more modern texts tend to refer to acute schistosomiasis syndrome. So this is 3 to 8 or about 10 weeks after infection. It coincides with egg production in the beginning, linked to those activities in fresh water, including water skiing and rafting. Fever is not essential. It can be mild. There's sometimes weight loss, dyspnea, chronic diarrhea, and your eosinophil count is often observed within the first few days to be elevated after the onset of symptoms. And that's sort of a picture of how the pruritic rash could look like. On the intestinal side, it's interesting. I went to the basic textbooks, Underwood and Bailey and Scott, and they try and attempt to link the various species to different organ systems, as you can see, and the same sort of theme of ulceration, recovery, stricture, fibrosis tends to repeat itself. And there's a lot of case studies where they do appendicitis and they perform histology, and then eggs are seen on histology of that appendix. So that's quite interesting. These are what this reference referred to as pseudopolyps, these white dots in the background. And then sometimes the features can be quite subtle. And they call this millimeter-sized lesions in the small intestine, but this case study doesn't describe, but they just say those were suspicious and they did biopsies. On the hepatosplenic side, Japonicum causes more rapid progression, so there are species differences. And to help you to anticipate what to expect depending on your scenario. And interestingly, on LFTs, at least at the beginning, LFTs tend to be normal. It's obviously as the situation gets progressive and you've got obstruction, it will change. And yeah, there's collagen deposition around the periportal spaces by activated hepatic stellate cells, and that leads to what is known as Simmer's pipe stem fibrosis. Splenomegaly can be significant, and these are just some features, a granuloma where you can see Manson's spine, although I don't know how they can say that's lateral, but and on figure 33.15, these white lines are the fibrosis the histologist would see. And then the species also differ. Mansoni tends to be an eosinophilic kind of granuloma, whereas Japonicum tends to be a neutrophilic granuloma in this text. Just useless information. Many of the articles for pictures of endemic areas have patients with these protruding abdomen with significant hepatosplenomegaly. And sometimes the varices, as in this guy from Brazil can be significant. This was a typical NEJM case study article. And then I've never heard of a thing called Gamma-Gandhi bodies, which are siderotic nodules, which are organized foci bleeding. And in the radiological picture, it's this is the black dots in the spleen. There are these organized foci bleeding with fibrous tissue, hemosiderin, and calcium. That's an enormous spleen, yeah. Pulmonary complications have also been described, and obviously this comes from portosystemic collateral vessels, allowing a path to embolize those schistosome eggs into the pulmonary circulation. They can have pulmonary hypertension, they can have heart failure, cardiac enlargement, pulmonary artery dilatation, and anti-schistosomal therapy may precipitate further embolization into the lungs. So just something to be aware of, I would think, associated with coughing, wheezing, and pulmonary infiltrates. Genitourinary is quite fascinating, and from our country, female genital schistosomiasis is very intensively studied in KwaZulu-Natal, and is obviously the additional link to HIV transmission linked to the ulceration in the genital tract, and obviously KZN is a hotspot. Further to that, males can also have involvement of epididymis, testicles, and the spermatic cord, as well as the prostate. And so here in the bladder in B, we see bladder wall polyps, and E is a picture of a sandy patches that you might remember from undergrad. Here is another example in C with multiple polypoid masses that urologists may see, and another example of pseudopolyps in a case from Mali, those bumps on the side. There can be pictures of calcification, as you can see there. And this is how squamous cell tumor would look. So that dense white area next to the pubis bone. This was an unusual finding during a prostatectomy, and this patient visited Mali 20 years earlier. Things come to haunt you later. I wonder how many teenagers who go for their gap year end up in something like this. Glomerular disease is quite interesting, and June, Fabi, and Tina has done a lot of work on this as well. And so the African Association of Nephrology has a whole classification to look at the glomerular damage. And here there's a link with hepatitis B, hepatitis C, and obviously these phenomena are immune complex formation based, as well as direct podocyte injury, IgA production, and the co-infection. Neuroschistosomiasis is interesting, where in Mansionine hematobium, it's myelopathy. In Japonicum, it's more brain involvement in broad strokes. And it's a medical emergency. And here are just some pictures. A shows diffuse signal prolongation in the spinal cord and the conus. And in B are the arrows point at punctate enhancing nodules that form a kind of a mass. This is a feature of cerebral schistosomiasis, and in B, there's this enhancement area with punctate nodules. That's quite phenomenal. Another picture where parietal and left parieto-occipital subcortical mass lesions can be seen. I never realized it would be this phenomenal. And then from the skin side, we started off with Katayama and soma is itch. But this is now when the eggs migrate and end up in the skin, and these can be papillus or plaque-like. And then I just thought this was interesting in a breast. So that's a mammogram, and in these lesions with a red arrow, those calcifications turned out to be schistosomiasis.
We had somebody in Malawi.
You had somebody in Malawi?
Yeah,
Yes.
we thought it was a cancerous mass, and we were.
That's unbelievable.
We sent it off, and lo and behold, it came back, and it was
unbelievable. All right, so start off. What's the condition on the full blood count? So up to 60% can have an eosinophilia. Eosinophilia can be seen in CSF if there's neurological involvement. With bleeding, you'll get an iron deficiency anemia, hypochromic microcytic anemia, and then thrombocytopenia is probably kind of a due to the portal hypertension, and probably is part of a red cell fragmentation syndrome, I would think. Liver enzymes rarely elevated, and this text said even in hepatic fibrosis, which I thought was quite interesting. In any fever, malaria, and then this link with salmonella is quite interesting, because salmonella tends to parasitize the gut of the worm and become an ongoing focus, which is just unbelievable. And then to think about hepatitis B and C in addition to HIV when you think of co-infections. These were two studies from KZN, and it was just to show Ascaris lumbricoides in one study up to 18%, and in the other study 25%, with Trichuris trichura 26%. And when we rotated at Profreen's parasitology lab, we had many cases with multiple things. I remember, like, how is it possible with the cases that you trained us on many moons ago in 2006? Anything and everything in medicine has differential diagnosis to consider, and obviously the features form a picture, and you'll immediately place the clinical entity. But when you're stuck and it's one-off features, consider other reasons additionally. So this is a summary of the diagnostic approach, and much of this was based on UpToDate, which the UpToDate articles are written by the Belgian guy Clearings, I think is the author's name. He features quite a lot. And then obviously before we published, I asked for a friend to look as well. So to think about, are we dealing with a traveler or are we dealing with a patient from an endemic area? And the starting off point is different. Serology in the one, antigen testing in the other. This link between or move over from acute to chronic means that if you have a prominent exposure and initial testing is negative, this is a case you will follow up. Because we've had scenarios where everything, even PCR, is negative, and then later it's a disease in evolution kind of thing. And how I try to think about this is also to save money, that we try and be sensible and not throw the whole kitchen sink at the workup. And then I also just included much of the ectopic phenomena will come from your histological findings. Sometimes it might be an incidental finding on a bronchial washing microscopy, although I think at AMPATH we've never seen that. And then PCR can be done on CSF in neuroschistosomiasis. So the schistosoma, Mansoni, and hematobium eggs are on the bigger side compared to the other parasites eggs that we might see in stool microscopy. Japonicum smaller. On the microscopy side, most texts, when it comes to urine collection, suggests to get specimens around lunchtime between 10 and 2, where maximal ovar secretion occurs, and they even goes too far to do vigorous exercise before collection to improve your yield. And if the epidemiology is strong, to do several urine specimens, not just one, and rule it out if one is negative. The same approach for stool specimens to repeat. There was one text that suggested a 24-hour stool collection, but I don't think this is practical. And when I was a registrar at WITS, we had our chemistry registrar room was in the stool room in chemical pathology, where they did the fecal fat. But all of that has fallen, by the way, archaic things. And then you have the option of a rectal snip as an additional place to go and hunt. The eggs differ at the placement of the spine, and Schistosoma mansoni tells you it's on the side. And then your Japonicum eggs and Makongi don't have a spine. And sometimes on histology, you can see calcification in what remains of that egg. This was an interesting study, and it was prompted whereby we got a urine specimen, and there was Mansoni ova in the urine specimen. And we checked it and double-checked it, and it was a good quality specimen. And so I hunted the literature and came across this article from Cameroon in an area that had dual Mansoni hematobium infection endemic. And that these authors suggested, because the ratio between male and female worms are different, that there's hijacking of each other's partners kind of thing. Although I've not seen other articles replicate this sort of thinking, but I don't know, is this a hocus pocus?
No, it's established.
It's established, okay.
Accepted.
Yeah. I've only had this once at AMPATH, which is interesting. So antigen testing is also on offer at AMPATH, and these are gut intestinal sort of compounds or proteins, and in blood we can measure circulating cathodic antigen, and in urine circulating anodic antigen and circulating cathodic antigen in urine. The CAA we get from the University of Leiden, and they have ongoing work that interestingly is coming to an end towards the end of next year. So there's now a huge process to identify a new source of CAA antigen testing. And on the urine side, there's also some development in coming up with a point of care CCA urine antigen test once this is no longer available. And Louis van Rooyen, our previous immunology head, mentioned that the CAA is as sensitive as one worm pair. So that's what I always remember from, he was completely into antigen testing. And serum CAA can be detected as early as 4 to 6 weeks after exposure, and is dependent on infection intensity. Our friends or nightmares are antibodies, because there's a lot of misinterpretation on antibody testing. And in a nutshell, you can have any variation on a theme lifelong. In general, when you're at med school, an acute infection, M goes up, and as it goes down, IgG goes up. But in this entity, our experience have been that initial pattern, for some reason, can remain lifelong. The Euroimmune assay for IgM is geared towards the adult worm. The IgG is geared towards the ova, and the immunocap fluoroenzyme immunoassay against the adult worm. And so I think people don't distinguish between endemic and traveler and try and do a one-size-fits-all approach. And then if this doesn't change, then they think we need to continue treatment. And in fact, it's your microscopy and your antigen testing that is used for follow-up, not antibody testing. PCRs, more or less overall in most studies, high sensitivity, high specificity, and they are expensive, and it does require specialized equipment. It is available at our lab. There's one article from Ghana showed that the CT values in CSF much higher than in serum. It can be done on urine, stool, blood, CSF. So when I wrote this initial article, I thought from a cost point of view, and we need to try and cater for public sector and private sector. And microscopy is going to be the cheapest, and PCR and serum CAA are more or less equivalent. So it's on the expensive side. And here I just put this in two different references. This is from 2024. Depending on the molecular detection, there's some discordance between real-time PCR LAMP and quantitative PCR. And in this article, they don't list those. They just say high and high for sensitivity specificity for PCR. On the histo side, an interesting fact is some texts say acid-fast staining can help to distinguish Mansenine hematobium, although some question the reliability. And repeat pathological studies should be prompted by eosinophilia, hematuria, and persistence of symptoms. And so in an endemic area, they suggest no sooner than 6 weeks following treatment, but you may have to follow up that case up to 6 months to understand what's going on. And in non-endemic areas, this text suggests 3 to 6 months after treatment. And that's because Praziquantel targets the adult worms, not the eggs. And so you can have the phenomena come up again later, requiring retreatment. So from the acute side, Somers H just symptomatic. Your acute schistosomiasis syndrome or Katayama, a combination of steroid therapy plus Praziquantel is what is suggested. The effectiveness of a single dose of Praziquantel in endemic areas varies quite significantly. In areas outside these endemic foci, whose parasite burden is usually low, a single dose is generally sufficient to reduce worm burden to negligible levels. But the thing is, we know patients don't tell us the whole story. Even when we inquire about what you did, tell us more about the nature of your water exposure. Was it the 40 minutes or a whole week kind of thing? So we need to ask more information on that. And so between the two species groups, Japonicum and Mukongai, they suggest a higher dose as opposed to hematobium and Mansenine. And At the follow-up, you'll repeat a dose of Praziquantel. In populations with high parasite burden, your follow-up will include radiology. And then I'll just very quickly go through this. You'll all have access to this for the different chronic manifestations, PEC, HIV, and genital schistosomiasis. Your hepatosplenic phenomena may require assistance from a gastric surgeon or a pathologist or gastroenterologist for portosystemic shunt or this transjugular intrahepatic procedure. There might be devascularization, splenectomy, etc. On the neurological side, prompt corticosteroid therapy is essential to limit irreversible tissue damage that occurs as a result of that intense inflammatory response, mainly towards embolized eggs. And interestingly, they mentioned look out for concomitant strongyloides with the use of these high steroids in these cases. And Praziquantel can provoke an inflammatory response and paradoxical worsening of neurological symptoms, also to watch out for that. That's just a picture of the TIPS procedure of a placement of to breach the fibrosis. Interestingly, historically, people used arsenic-containing salvarsan and anything in between. None of these, I think, have are currently in use. It's just historical. Praziquantel focus on the tegument, so it causes vacuoles in the tegument of a worm. There's calcium ion permeability that is increased, and there's also a host response that assists in its effect. There can be paradoxical hypersensitivity reactions following treatment among travelers with acute infection, as well as in early chronic schistosomiasis. Praziquantel can be used in pregnancy, but they suggest discontinuation of breastfeeding at the time of treatment and for 72 hours thereafter. Interesting in kids, the bitter taste is what makes it very challenging in kids. And the product consists of 2 isomers. And the bitterness is mostly due to the S isomer of Praziquantel. So that's also quite interesting. True resistance remains exceptional. That's not really seen. There are some work on oxamniquin, artemisinin derivatives, and mefloquine, but none of these are really at the level of where the use of Praziquantel is. There's just no effective alternative. So from a prevention point of view, periodic mass treatment, there's a lot on that where they're going to school-centered programs. This is mentioned in the WHO document, but I think at the moment still, Profine, in our country, there isn't a program as such driven by the DOH. Is that correct?
No, they are making moves towards that.
But we're not yet
But
there.
we're not there.
Okay.
One of the problems is the high price of Praziquantel.
Aha. Yeah.
We pay ridiculous amounts compared to other countries. In fact, most of them get donated drugs, but we're not allowed to accept donations.
Oh my goodness. And so preschool children are less affected. So the SMF talks about using Praziquantel in patients older than 2 years. And so these periodic mass treatments can be done annually or biannually. Then obviously to look at what to do with the snail, interfering with the biology of the snail using molluscicides. There's a lot of work on vaccination, but none of these clinical and preclinical studies aimed at specific components of the different worms, fatty acid binding protein, tetraspanin, large subunit colpain, glutathione esteransferase. None of this is in routine to my knowledge. Is that also how you have it? Yeah.
That's what we need.
Yeah.
Yes.
And so this comes from an old travel journal. Avoid contact with water containing cicaria. They talk about skin cleansers and soap and vigorous rub down and applying alcohol to expose skin immediately after contact. Heat the water, cedar wood oil, portable water filters and water purifiers, etc. And then raw water can only be considered as being relatively free after 2 days. So in a nutshell, think about the exposure history at play. Think about, is the case from an endemic area or a traveler to an endemic area? What did they do there? To realize initial testing can be negative. Clearings and colleagues focus on antigen testing in endemic cases, antibody testing in travelers, and follow-up is not by antibody testing. And I think when I had this discussion with Prof, we had said from that, this was before COVID, I think, if it was an incidental finding in the workup of a target organ that you now get an antibody response, and that's the only feature to link that target organ system, maybe 1 or 2 doses wouldn't do harm, but that's the beginning and the end of it kind of thing. And obviously never to forget about malaria.
I'm going to ask the audience if there's questions.
Yes.
So we can take questions on there. But anyone in the room that has any questions? Or comments? Comments.
I remember some countries who employ expatriates. They would give, if they could, like we say, people with pets at home must be dewormed regularly. Once a year, they just get their Praziquantel. No testing, whatever. It was almost, I'm wondering whether it's such a bad idea.
Yeah, well, if one
we
in
have
40
it, but-
individuals are proposed to be infected.
I'm going to get tested tomorrow now.
So that can people hear us?
We should be able to hear from you.
Yeah.
The 40 or the 37 Belgium in fact.
Yes.
I think Lucilla's got a picture of the pond where they got infected.
Aha.
No Bilharzia.
Yes, yes, yeah. And I think in the text they actually mentioned that they could see
Like
the intermediate dose. They could see the snail. They could see it. It was unbelievable.
Sure.
I mean, I get frequent phone calls from GPs and
Yes.
stuff who have done serology, and frequently the IgMs are the only thing that's positive.
Yes.
But the patients have got really no symptoms.
Yeah.
They haven't really,
Yeah.
got a significant exposure.
Yeah.
They're adamant that they want to treat these patients with Praziquantel.
So I think
Why are they testing them in the first place?
exactly. Yeah.
If your pre-test probability is
It's-
low,
Yes.
then any positives likely
Yeah.
to be a positive.
So a lot of these patients are going to their GPs and have been told that, they were
tired. They're tired.
or they've been to an area and they've heard somebody else tested positive.
Yes.
So they were on the same holiday, now they
Yes.
want to, get tested. So,
Yeah.
yeah. And recently it's been a lot of patients traveling to KZN and they were swimming in the sea, in the
Yes.
salt water.
Yeah.
But they insisted on being tested and the GPs test them. And their IgMs come back positive.
This is an expectation management situation,
Yeah.
and latched on to these consultations that I get daily or
Yeah.
weekly. It's sort of random attempts into all directions. And I know, I can only just imagine the person sitting there with a case and you have no clue. And now you start out of just freaking out, what must I do? And but I think the thing about micro is it's linked to the epidemiology. What is the epidemiology at play? It's like Clostridium difficile testing. Is there watery diarrhea? Have you considered other reasons for the watery diarrhea? And was there exposure to not only antibiotics, but anti-chemotherapeutic agents with anti-neutrophil effect? And only then do you treat, kind of thing. And I mean, C. diff is also a weekly occurrence for us to explain all of this. And some things like the C. diff, the PCR can be positive for weeks. Yeah.
The other thing that I found that another group of doctors which have jumped on the bandwagon of testing for schistosomiasis is the psychiatrists.
No.
Yes, yes.
That is
They are
unbelievable.
sending multiple patients for serology. Patients, and then most of them are teenagers, young 20-year-olds, yeah, tiredness and or depression, and they're sending them for schistosomiasis testing
Crazy.
without any history of exposure or travel, whatever. And they're just doing it as a routine workup. Yeah.
So, because of the neuro. I see Charlotte's hand.
Yeah, Charlotte.
So you can just unmute. Should come out of.
Hello, everyone. Thank you, Pieter, for that wonderful presentation. It's schistosomiasis. There's just so many things to unpack and talk about. But I'll just want to say, just exactly what Tina was saying and what you were saying, from the NICD perspective, these patients are getting tested. There's no real indication for testing, but obviously these IgMs are coming up positive on serology. And then obviously we've had a clinician in one of the hospitals who was routinely testing everybody who had come to the practice. And so from the NICD side, we get a call then from the IPC nurse saying we have an outbreak of schistosomiasis in a certain part of the country. And, you know, this was the exposures, and it does take a lot of explaining, of delving, exactly like you said. It is very time consuming, but there does need to be more, I think, discussion and education of clinicians out there when it comes to the testing and especially the serological assays. But it does, I've had 2 sets of query outbreaks last year. And then this year there was one from Bloemfontein, and actually the environmental health practitioners and the university that deals with the snail vectors had to go out and do some testing as well, because it made it to the media. So, you know, it's a lot. It does create a lot of downstream effort on everybody's part. But I just thought I'd mention that. So it's interesting to hear your perspective, Tina and Pieter, as well. I think people need more education on the testing that needs to be done. Thanks.
I think for these conundrum cases, to source an opinion from a multitude of pathologists, a clinical pathologist, or get a micro, a heme, and a chem involved. And at Unitas Hospital, there's so often the cases, you can clearly see it's a clin path case. And we've had some extraordinary ward rounds where I get our those 3 disciplines and a geneticist and a virologist around the bed, and we support the pediatric nephrologist there and we have a beautiful round for an hour, and everybody adds their little part of the puzzle and access a different differential diagnosis for the feature being discussed. And in the private sector, there's this strong move to team sort of approaches. I mean, at Life Groenkloof, every Friday, there's a massive ICU ward round, and all the role players, including the speech therapists and the physio and all of that, and everybody contributes. And that's the way of the future.
But should antibody testing then not be discouraged if it's so
In a wrong
useless?
setting with a low pretest probability, absolutely. Yeah.
Well, so this initial publication was for Prof. Feldman's Infectious Diseases Update, which is a 4-pager, and then I contracted it into a 2-pager in an AMPATH update to disseminate to, I think I shared it with you, to share it with all our clients.
But it's updated. It's for travelers to endemic areas, you know.
It's just
that travel history.
and it's really it's sort of good that we have 35 people on the call. At 43 at some point, that's the utility of these meetings, is to discuss it and tear it apart and understand. It's you can never know it all.
So if we say travelers to endemic areas, where are the endemic areas?
Well,
I think Prof. Jones told me a long time ago we did mapping in the 1940s, but we haven't got current mapping. No, never mind.
South Africa.
Africa, but even in South Africa, I mean, I remember from Tukkies, we were told east flowing rivers, all the rivers flowing into KwaZulu-Natal, they infected. But the Orange River and everything flowing west and into the squeaky clean Cape area, you know, there's no Bilharzia. But I mean, because part of the hysteria we had recently amongst high schools and prefects and what have you, my understanding was they were swimming in cement dams near Pieter Dam. Now, is there a map that emphatically says there's no, so don't even start testing if somebody's swam in the dam in Artis or in Bella for that matter, because if we say you shouldn't be testing if the guy didn't have an exposure, then we can sort of kill it in the butt.
Yeah.
But he did say that were.
But was there
But even more specific.
Well, we're at the right altitude because it's below 1,800 and we're 1,700.
I recall an article. I want to see if I can quickly find it.
Well, while you find that, let me just say that Albie's right. The detailed mapping that produced that enormous atlas,
Yeah.
that weighs 20 kilograms, that was there's been nothing in that sort of detail since the mid 1980s. So and you know, populations move around, they change. They you get new areas.
Yeah.
And if it's environmentally suitable for the snails, then you might well get new pockets of transmission set up. So it's difficult to know at a detailed level exactly in those general areas where the transmission may be, and it may turn up out of the blue like these Belgian travellers. That eco lodge had been letting people swim and canoe in that river for years without any problems. So something had changed.
Yeah.
So this is an old article that I just remembered. It's from April 1989, Pretoria, Joubert and de Kock. Research Institute of Diseases of Tropical Environment, SAMR, Department of Zoology, Potchefstroom. And they have this dams in the transitional region in which the intermediate were found. Boskop, Bronkhorstspruit, Darthrode, Dam at Fountain, Howison-Poort, Makwasi, Nahoon, Nooit Gedag. But I haven't seen something similar to this, and you can see the years there are Boskop, Potchefstroom, 1966 to 1977, Wenzel, Schweizer, Reineke, 1958 to 77. But this is rightly said as it's from the Dark Ages.
Yeah. That's where it might be.
So we have a friend, Jackie Brown's husband, Jackie Brown from Paraguay, ICU.
Oh, yes.
Whose husband is an LLB and was a travel agent all his life. Then had a heart attack, got rid of his partner in the travel agency, and started writing books on snails. And he's now published his third 700-page volume on the snails of Africa. But I think he's the land snails, but he concentrates on the carnivorous snails of Africa. But I'm just thinking, somebody like Ken may have contacts in the snaily society, the Dr. Doolittles of our world, because isn't that where it starts? If the snail isn't present, then it's not a problem. So isn't there maybe amongst the zoologists a good survey of what's actually going on with snails in our sub region of the continent?
There might well be, but I think some of the old snail experts, like Connie de Kock and so on, are no longer with us,
Yeah.
no longer active.
Yeah.
And I really don't know to what extent that sort of work is going on. It seems in Bloemfontein there was an expert who could investigate
You
that.
sent me the report.
Yeah. Who could investigate that particular the incident.
Yeah.
But that's not generally the case.
Spent a week finding no snails in that dam at all. So
I've done about a week, but
Dug around. I'm gonna close off online. I think we're gonna carry on talking around the table. It could be ongoing, but if anyone has any questions, they're more than welcome to reach out. I think my email is always Albie's email on the invite, so you can, if you have any questions, then we can pass it on as well. So if there's any further.
And we're always at your disposal. I mean, really, I think always phone, even if it's just to share thoughts, throw ideas around, and sometimes the conversation prompts questions more than anything else, or gives some ideas to throw the net out and see.
Maybe we're missing something else, some other disease or something else.
Absolutely, a mimic.
Yeah.
I just want to end by saying I think Dr. Ekermans put so much effort in this. It's important for people to know that it's going to be on our YouTube channel. So you can go and look at it at your leisure and freeze shots and what have you.
Yeah.
I think there's lots of things.
There's so much information. Yeah. Thank you so much.
Yeah.
Yeah. Awesome. Great. Okay, we'll end here.
All right. Goodbye, everybody. Thank you.